relationship and trust with anybody. So um, today we have Ms. Mukta with us, who is a clinical psychologist, and she has done her MPhil in clinical psychology from Amrita Institute of Medical Sciences, and she is a registered clinical psychologist as well. She is working as a consultant clinical psychologist with Dilasa Palliative Care Center at Goa for the past 3 years, and she also has her own practice. So, welcome, Mukta, and I request everybody to ask your doubts first. All of you have gone through 7 modules of communication. Anybody?
Hello, good afternoon, everyone.
Yeah, please go.
Hi, sir. I had a question that, communication, like giving the bad news specifically, like in our cultural context, how do we take it? Like, because it's not just your husband or wife, there are like so many people, like maybe 5 or 10 people around. So, how do we do that in keeping in mind so many people would be coming or joining, and a conversation or communication is difficult when there are more than 5 people or 10 people to focus on a patient. So like I would like to know how do we draw or how do we tell some people to go out or leave? How do we manage that?
Okay. So for hello.
Yes, ma'am, we can hear you now.
Yes.
Yeah. Okay. Yeah. So first of all, I think this is a very we always take a patient centric approach, right? So we are always going to usually when we are about to break a bad news and we are going to sit people down and talk to them about it. Usually, at least personally, what I tend to do is I'll ask the patient, like if it's a he, I'll ask them who is it that he would want to be there with him when we are going to discuss something important, and then choose only those people and ask only those people to come in, rather than just allowing anyone and everyone to join.
Yeah, I agree. And you can actually, this is going to happen in a room. And as Mukta told, um, more people are not needed. Actually, who are the people comfortable with the patient? And if the patient feels that, okay, this person only should be with me, and some patients might tell you that, no, I don't want anybody. So it is according to the patient. And usually there will not be 5 or 10 people. The patient may ask for one person or maximum 2 person. So it's otherwise. So this is how usually communicating bad news happens, and you have to actually set up the scene, uh, give enough privacy, and all those things like arranging the furniture, maybe if possible switching off your mobile phone, because that is going to be a constant barrier in communication. So all that will set scene for communicating.
And the opposite one just like when a patient doesn't want anyone to be there. So in that situation, because like, us, I know how much ever they are strong, they need support. So how do we convince them to like get in some relative or some to inform them even for later?
Mukta, would you like to take that?
Yeah.
Or-
Okay. Yeah. Yeah. So usually it's it's not going to happen like suddenly, but of course you would first of all want to um, find out why they don't want anyone to be there. And then secondly, of course, as you said, you can always tell them why you would want, why you feel the need that there has to be somebody else along with them. It's not just them alone. And then you could suggest, like, let's say you would definitely know who the primary caregiver is. And then you could ask the patient whether they would want them, or is there somebody else that they trust more, and then they would just. So it's not going to happen like suddenly, but of course you will have to take some time, talk to the patient, and then do it. So would you like to add something to that?
Yeah, I agree with you, Mukta. And there might be many reasons why why the patient is telling nobody is not needed. So sometimes patients might protect the family members from the severe emotional stress that is going to happen. So they don't want to burden them with. But this is only one reason. We should not assume why patient is telling. So always explore is the dictum, and but sometimes when certain diseases like HIV is diagnosed, it is actually conveyed to the patient. But it is also important for us to make them understand that they would further need the help of their loved ones. So that we have to slowly discuss with the patient and make them understand.
Yeah, like sir, you said, I think here, like, breaking the bad news and collusion will go hand in hand. Like you said, sometimes the patient wants to collude with us that, don't tell my family about this. So dealing with that is going to be a process. It won't happen in a session.
Anybody else?
I also see I also see a comment in the chat box, and I totally agree with you, sir. I know that the current situation is not really ideal to the kind of work that we're doing, and we're not saying that it's going to be easy or that this change is suddenly going to happen. But at least when we know what is the ideal, only then can we start to, like, at least try and bring a change in the kind of setups that we work in.
And I wanted another, I mean, it's just for additional reading because that, like, as a medical doctors, we are never been taught how do you communicate. We learn from the doctors or verbally, but there's no official education for how do you communicate with patients, breaking bad. So, is there any other place where we can learn further? If I would like to hear from Mukta, like some documentations or like.
Yeah. So you mean specifically about breaking bad news, right? Or in general communication?
In general communication also, and specifically breaking bad news, because that's where the maximum hesitation comes for us
Right,
to do the.
right. So I think in your communication sessions, probably the ones that you watched or attended, you might have heard of the
Yes.
protocols that are used. So
Yes.
I'm not sure whether they were shared with you, but because these are public, like, open access papers. I have two of them. If you want, I can share definitely. So they're very detailed, and you could definitely go through them to find out more about it.
Okay. Yes, we
So
have the resources.
there is one book called Medical Communication by Dr. Robert Buckman, who is a medical oncologist, I think. He has written a very beautiful book on medical communication. So that might be available in Amazon or somewhere. But if you look at the palliative care libraries, it would be available.
Sir, sorry to interrupt. We do have some charts in our chat box.
Can you please read? I am unable to.
Sure, sir. Dr. Isha is
Yeah, I'm reading. I can see.
Hmm.
Okay, Mukta, would you like to take this? The first one
Yeah.
regarding the
Yeah.
patient with CA colon and the brain metastasis and how to break this news to the patient.
Yes. Yes. So again, it's not going to be easy. First of all, you'll have to talk to the wife, just check if there is collusion. Because I mean, considering that the wife knows and the patient doesn't. So that comes first. And then if there is any hesitation from the wife's end, you would have to resolve that and obtain permission to, okay, I'll talk, like, let us talk to the patient and then talk to the patient about it. Again, all the standard ways of, like what we generally do when we break bad news. So we first find out what the patient is thinking, what is their perception, why they are thinking that, and only then give them a warning and then tell them the reality. But of course, very gently, considering the situation that you are in, and be prepared that there is a reason why we call these uh, difficult communications. Regardless of what you do, they are never going to be easy. They are never going to go smoothly. They are never going to, I mean, we can't expect patients to take this well. So be prepared for the aftermath of it and be prepared to deal with that. So it might be denial, it might be anger, it might be depression, any of it, whatever comes up. Make sure that you are making space for them to process those emotions, that they are understanding what you are telling, and mainly how they are dealing with the emotional reaction that comes and how you are able to support them. That is what is going to be more important here when you think of this particular case. I mean, of course, that's my personal opinion, but
Okay, so there is no easy way to communicate bad news. The bad news is bad news. Whatever you are going to communicate is called bad news because it is going to alter the patient's life. Okay, and in this patient, then first of all, as Mukta told, we have to actually his wife may tell you that no, don't tell him. So those all things can happen, and at last, if the patient wants to know, then first of all, we have to find out what is his insight about the disease as of now. He might not know anything about what is happening to him, including he had a CO colon. I'm not sure. So first of all, find out what is his insight. Ask him, what do you think, or what is the reason why you have this symptoms? Then he will tell you a story. Then you just listen to that and get clarification as and when needed. So basically, it's just a storytelling from which you can find out the insight of the patient. So you will understand, okay, this patient knows this much. Then maybe probably you have to go and ask, would you like to know more about this? Even if it is something serious, that is called a warning shot, because you are giving a warning to the patient. When there is a riot going on or when there is a mob attack, police will fire to the sky, not to the patient, not to the chest of the mob, because what does it indicate? It's a warning shot, isn't it? So firing to the sky indicates that if you do not disperse now, next shot is going will be at your chest. So that's a warning shot. Likewise, you are giving a warning shot, and a patient says, yes, I want to know. Then you can actually continue from where he stopped. You told me, okay, this things, and now you know the situation has changed, and you had some abdominal problems, and that's why the doctor asked to take a scan of your abdomen, and in that scan there were there were some problem. You have to actually pause there and see the reaction of the patient, body language as well as the verbal language. And if you think the patient is favorable or he want to know more, then you go ahead and tell, in the scan there was a swelling in the liver. Stop there and listen to him. Then so that's how you will go, and maybe in the next step you can tell him, okay, that swelling is not a good swelling, and next step, it is the from the intestine the cancer has gone to liver, and that's why. So that's how you have to break it in steps, and at each step you have to pause. So the information should be given in small chunks, and the patient so it should not be ambiguous, so that patient can understand. And actually, if you think that, okay, patient is not interested, he is looking outside and he is not facing you, that means patient is not interested to hear anymore. Then in such situation you can tell him that, okay, I understand that now you do not want to hear anymore, but so we can stop this conversation here, but if you want to hear more, I am ready to give you more information, please approach me. So that's how you have to go and tell him.
I think that was a very nicely explained example, sir. Like very clear.
So time management, I can see one comment on time management. Yeah, that's very important. All of us are very busy, isn't it? So what you have to understand is each patient doesn't require equal amount of time. And you have to actually prioritize which patients needs more time. So even for some patients, a smile at them would be a good communication for them. But there would be some patient who is totally emotional, and then you have to give some time. So it's so prioritize the patient. That's what you have to do in a busy OPD or wherever you are. Prioritization is the most important thing whenever you have many patients to communicate. So please understand that even your good body language, non-verbal communication would make the patient understand that, okay, you are friendly, or you like the patient or something like that. So that's enough for some patients. Anybody else? Only Rithi completed communication module. Nobody else completed. Okay. Mukta, if you have something on communication, can you
Yeah.
please share from your slide?
Yeah.
There
Yes.
is one more
Yeah.
comment by Dr. Anju. If a patient's relative says some irrational treatment not actually recommended for cancer, and
Sir, what I meant is like I have actually suggested intrathecal chemotherapy for a patient. The patient
uh,
had four relatives who are staying abroad. They are telling that those kind of treatments are not there for cancer, but I actually recommend it because of the high risk case, because it's a high risk case. But they
mm,
are actually not willing for that. But I know that it is good for him.
mm,
So how can I convince them that this is actually required when all of their relatives are actually against it?
mm. This is very difficult because as doctors we can advise them, isn't it? And then we can explain what are the advantages and what are the disadvantages. It is for the patient to decide whether they want to do it or not. It is not, or we cannot actually compel them to take it. It is beneficial, but I think if you have explained it properly, and if they are not willing, you have to write it clearly in the case sheet, document it, because so whatever you should do ethically you have done, and then you have to think that okay, rest it lies with the patient and family. We will not be able to do. We cannot tie him and give him intrathecal chemotherapy. So it's up to them. You do your duty, and if you think okay, this is very very important, then probably you have to select one of the family member and talk to him, who would be a decision maker in the family, and tell him I am telling you because I feel you are the most one of the most important person in this family, so that way you are also giving some credit to that person. Okay, this doctor understand I am an important person. So that might be one technique. So otherwise I cannot think of any other methods, and even you can also ask them to take a second opinion, if possible, to one in another hospital, and if possible talk to that doctor and send him, if you really think okay, this is going to be beneficial for the patient. Okay, I think Mukta, you can.
Yeah. Senior, can you just enable my screen share?
Ma'am.
Yeah.
Ma'am, you already have the sharing rights.
No, there's another. I've logged in from two. My laptop account is still disabled.
Okay.
It's also Mukta.
Yes. You can share the screen.
Yeah. Okay. I hope it's visible.
Yes, it is, ma'am.
Yeah. Okay. Fine. So to begin with, let me just give you an overview of what I had thought we could do is, first of all, I'll just give you a very, very brief summary. I'll try to be very quick about it because of time constraints of what you all have already covered in the communication sessions that you would have attended or watched. After that, and I think we also have a case presentation by a participant. So if time permits, I have some case scenarios of good and bad communication, which we can go through. And then in the end, if time permits, I have a patient story that I can also share with you. Right. So I'll just quickly go through some key points that we all need to keep in mind and keep remembering, speaking of communication. Most importantly, the very basic thing being that we all benefit from good communication. And when I say we, the entire team, including the clinical team, the patient, and the caregivers, and we all have to face negative consequences of bad communication. We all have barriers to communication, of course. All of us go through hindrances that we have to face, us as well as our patients. But with the right approach, we can definitely overcome these hurdles. And this right approach basically requires us to be respectful, to be empathetic, to build trust by being honest, and to have unconditional positive regard for our patients. Secondly, so we could say that these are basically the core principles of good clinical communication. Secondly, as I said, we need to pay attention to the nonverbal channels of communication, pay attention to what is not said, but you can still see it and observe it in the patient, and as well as what you are communicating nonverbally to your patients. Thirdly, quickly refreshing some do's and don'ts. Do ask open-ended questions, do listen mindfully and actively, make sure you're acknowledging and validating the emotions. Let people process, maintain confidentiality and respect boundaries. Always inquire patients' reasoning behind their behavior or whatever that they're doing or saying. Always explore. Keep checking for patients' understanding at every stage that you're communicating. Be honest but sensitive. And always summarize and follow up and keep the channels open for communication for any doubts that they might have at any point of time. And what you do not do is you don't moralize or philosophize. Don't compare with other patients and tell them that, see, that other patient is also in pain, but they're not crying and things like that. Never be condescending to them. Always be respectful. Do not use a lot of jargon, technical terms that the patient does not understand. False reassurance and lies is a strict no. Please don't do that. Sympathy, of course, all of us know nobody likes to be pitied. So that's a no. And again, thoughtless honesty is also a no, just like lies are a no. What I mean by that is it's not just about being honest. It's not just what you say, but also how and when you say it that's going to matter a lot. So make sure you're being honest, but you're also being sensitively honest. And then if we have to have a roadmap or steps for communicating, we would basically start with building a rapport and open up the discussion with the patient. And then we would gather information. So always remember the cardinal rule is ask before you tell. Always ask before you tell. So gather information. What do they already know? What and how much have they understood out of what was told to them? And their perspective. What is the meaning that they have attached to the things that they have heard from the doctors or the treating team or anybody else? So gather information first before you start talking. Only then you go to sharing information. After which, make sure that you're reaching a collaborative agreement on the problems and plans. It should not be unilateral. It should not be only you telling them what to do. It has to be a collaborative process. And then you close the discussion sensitively, keeping the channels open, as I said, that they can always approach you for doubts. Coming to especially difficult communications, firstly arises the issue of collusion, where again we need to handle it sensitively, validating their concerns, explaining gently the importance of disclosing information. And when it comes to breaking the bad news, of course, we have very structured protocols which will help us, the most popular one being spikes. As we know, set up the interview, find out patient's perceptions, obtain an invitation to share information, give knowledge, as sir already said, in very, very small and palatable chunks, pausing at every step to check understanding and to allow for emotional reactions, if any. The E in spikes basically is empathy in the face of emotions. And lastly, strategizing and summarizing along with the patient. And be prepared for the reactions, as we already discussed. So it might be anger, it might be denial, it might be depression. Make sure that you realize that these are normal grief reactions and they will help process grief if we deal with them adequately and properly. And do not take these emotions personally, especially emotions like anger. Make sure you stay calm and empathetic. You validate, you make space for these emotions to be expressed, and you're supportive in the face of these emotions. All right, and always remember why we are doing all of this, because we might not be able to change the end outcome of it all, but we can definitely affect the journey and make it a little easier for the person going through that process. So I hope that this has jogged and refreshed all your memories about what all you heard in the sessions on communication. Now, based on this, I have a few scenarios here. Some showing good communication, some not so much. So basically, what you're going to see on the screen is you'll see something that the patient has said, or some scenario or some situation, and a few responses, and you just have to choose which of these is good communication or which of these would be an ideal response according to you, right? You can all share your answers or responses in the chat box. So this is the first one. My patient says, I can't sleep, I try so much, but I just keep thinking and I stay awake. Okay, somebody is saying 4. Can we have some more responses? What do you feel? Okay, most people are saying 4. That's definitely good. All right, fine. Okay, moving to the next scenario, my patient has missed an investigation I'd asked for and says that he couldn't get it done because it was harvesting time on his farm and the farm is the family's only source of income. And out of these, which one would you choose? Again, most of you are choosing 4, of course, because in the 4th one, again, we are validating his perspective, his viewpoint, and at the same time, also making sure that we let him know why this particular thing is important and that he needs to get it. Right? Yes. Okay. Is there anyone who feels the 3rd one is okay? The 3rd response. Anyone? Okay, all right. Moving to the next one. My patient says, so I've spoken to my patient about a few choices that they have to choose from. And they say, I've been thinking so much about the choices you explained. At times I just get confused. I don't know what to do. Is there anything other than 1 that you would want to choose? For all those who are saying 1. Yeah, so this basically has two correct options, 1 as well as 3. Okay, I see somebody has said 2. Sir, can you tell us what made you say 2?
We can reassure the patient that there is nothing to be confused about. That is the first part. It's straightforward, clear-cut choice, but you are just we have to put some responsibility on taking decision to the patient or the relatives. You are just and also we are making a comment that just don't overthink about that, like that. I have thought like that.
Okay. Okay. So, see, first of all, it's very, when people are emotionally disturbed, reassuring can be very, very invalidating sometimes to the patient. Let's say, for example, my patient is telling me that I'm scared, and I'm saying there's nothing to be scared of. Yeah. So basically, I'm not acknowledging that, okay, my patient is scared, and I need to make sure that I find out what they're scared of and deal with that as well. It's not because um, saying that there's nothing to be confused about is your perception, because for you the option is very clear, but for the patient probably there is something that genuinely makes them confused. And when they say that they are not able to come to a decision when they are confused, it's also a hint that, okay, there is something that's disturbing them, and we need to find out what is it that's disturbing them, rather than saying don't be confused.
Okay.
Yeah.
Mukta, I would like to make a comment here.
Yeah.
This is if you look at the option 1, actually here we are respecting the patient's autonomy and asking the patient to take the decision. Okay, so it's you have some products which you need to sell. So there are 5-10 things in front of you, and you are asking, you have explained about each advantage and disadvantage of these 5 products, and you are asking the patient to select which one do you want to select. You can decide, but in the third option, you are telling, okay, you can see there are many things, and you are not experienced with any of this, so that let's discuss, and we together can come to a decision, which is known as shared decision making. Okay, so that would be a better choice, because many a times patients alone may not be able to take a decision, and if you are also involved in that after explaining all those things, then that would be good. Otherwise the patient might not be able to take a decision. So shared decision making is the thing which is always good.
Yes, yes, sir, definitely. And I think in shared decision making, patients also feel more supported by the doctor. Otherwise, it's like we are just giving them information, and then they are just on their own and they have to decide. When we give them that option of shared decision making, they always have that, okay, my doctor is with me, and they'll help me take a decision. So definitely. Okay, I think we can go to the next one. Yeah. So I have explained the report to the patient, and which one, like, what should I say after I've explained the report? Okay. Okay. fine. So I think most people are on the same page and saying that we should ask for doubts. Okay, fine. Okay. The next scenario is a 15-year-old boy is asking, doctor, what has happened to me? Can you see the slide, or it's not changed? Okay, yeah. So when consider a 15-year boy is asking, doctor, what has happened to me? Yeah, Riddhi, you're right. There's none of the responses is correct. This is actually an actual scenario where a 15-year-old boy diagnosed with ALL, leukemia, had asked the doctor what has happened. And thankfully, the doctor was a really good doctor and actually sat him down and explained everything to him. They spoke to him about what a bone marrow is and like everything in detail. And after he knew about what has happened, he was so relieved. He actually came and told me that, I had a feeling, I knew that something serious had happened to me and that people were not able to find. And then and only then once he got to know what had happened, it was much easier for him to accept and then face what was coming. So ma'am, when you say that 3 could be correct and it could be the start of the conversation, it's considering that it's a 15-year-old boy, and even otherwise, it's if your first sentence is you'll have to be strong, the boy is going to get scared. So instead, it's I mean, of course, depending on from person to person, this will differ depending on what you'll get to know more about the patient and what kind of a person that, like, what's the personality of that patient, and only then you'll be able to decide. But generally, it's rather than just saying that, it's going to be a difficult journey, you'll have to be strong right at the beginning. You take your time, sit them down, and then explain, and only then, because a 15-year-old boy might not even know that, okay, this is something serious. Yeah, the boy has an intuition that something is wrong. But again, see, the thing is, this particular boy, I mean, let me just give you a little bit of background. He's a kind of person who deals well with facts. So when we explained what had happened biologically, cancer was not a scary thing for him because he knew what that means. And then we could tell him that, it is going to be difficult and there is going to be pain and all of that, and you'll have to be strong. And he was ready to be strong by that time.
If you look at the first choice, it is a false reassurance that is given to the boy. It is nothing to worry about. So that's a false reassurance. And the second one, try not to think about why don't you try to focus on your studies instead? It is important here for you. Yeah, that's a factual response. But that is not going to help the boy at that situation. And you will have to be strong. It is going to be a difficult journey. That's also true. But I think that is not the first sentence that we need to respond with. So I think first of all we have to be or we need to tell him an empathic or empathetic statement. Then while discussion, then maybe you can tell, okay, I feel that, okay, this is going to be a difficult journey. That should be okay. But as a first response, this would not be a good sentence to tell him. And the other one, I have explained everything to your mom. She will tell you. That means we are withholding information from the boy, and he might think that, okay, there is something serious, and that's why the doctor is not telling me. So, so these are the thoughts that they will have.
Yes. Okay. Yeah, I have changed the slide. Can you see?
Yes, yes.
It says, doctor, would there be any side effects? Is what a patient is asking. If you had to choose one, what would you choose out of these four? I think again, people are saying 3. Are you worried about it? Because you can explore. Yeah. So as we also saw in the summary, and as Sir had also discussed earlier, always explore. So whenever a patient is saying something or behaving in a particular way, always explore what is it that's going on in their mind, rather than just immediately jumping in and reassuring, or jumping in and giving them a solution to it or something like that. Never assume. We can of course explain about the side effects, and we will be doing it. You cannot not explain about it.
So you can think of yourself in the situation, and you can think of the difference that you are going to make if you tell the first sentence. Don't worry about it. Be positive. And another sentence that you are going to tell him. Okay. Are you worried about it? Then that will actually give us a chance to understand what are his worries, and then reassure him. That is going to be more beneficial than directly telling him, okay, don't worry, or that is actually false reassurance, because we know that there are going to be side effects. So first of all, let's make an empathetic statement that will actually make the patient understand that the doctor is really concerned about me and my disease and the problems that is going to have. So that is the basic thing, and that will actually increase the satisfaction of the patient and also the trust. So telling empathic statement or empathetic statement is very, very important in communication. Whenever the patient is emotional, or whenever they have questions like this. So even in collusion, collusion, the caregiver comes and tell you that, doctor, please don't tell my father regarding this. So then you have to make an empathetic statement. Okay, you are worried, thinking that I am going to tell the diagnosis to your father, isn't it? So that's an empathetic statement. So that makes understand the son that we are really concerned about his situation. So that's what we are actually expressing with empathetic statement. So it is applicable in everywhere in the communication.
Yes, I think, okay, Asha ma'am has said, can we ask instead, what side effects are you worried about? Ma'am, if we say that, I mean, nothing essentially wrong about it, but that's basically we assuming that the patient is worried about the side effects. So ask whether they are worried in the first place, and only then you can explore further, definitely.
There is nothing wrong. We are trying to improve what we are going to ask. That's all.
Yeah. Okay. The next scenario is the patient is refusing to take medications. Okay, I think everyone is saying one. Okay, fine. I think there is no doubt about this one. Everybody has said one to this. Okay. Okay, all right. I am done with the case scenarios. I have a patient story, but I think I will keep it like if we have time later, we can maybe talk about it. Because I think we also, sir, have a participant presenting a case.
Yeah, we can take that patient story, which I think Riddhi is going to present.
I will share the case from my end. Is it visible, ma'am?
Yes, yes, it is. Thank you. So, good afternoon, everyone. My name is Riddhi, and I've been working in TB. So we have patients who are like considered palliative care when there's no treatment option available for, especially for XDR TB, or also when they are all diagnosed with XDR. So the case here is a 30-year-old male was diagnosed with bilateral infiltrative pulmonary TB, which was XDR. So XDR means extensively drug-resistant tuberculosis, which is resistant to the newer medications, new group medications. Group A, there are different classifications according to the WHO. So the main important drug is bedaquiline, moxifloxacin, linezolid. So here you see the patient is already resistant to all of these medication. Next, please. So the main presenting complaint at this moment was coughing with expectoration, breathlessness on exertion, and intermittent fever and loss of appetite. But I would like, next, please. I would like to tell you the story behind it, the past history, where the situation is right now from the beginning. So the patient was diagnosed with drug-sensitive TB in 2013, where he did not, like, probably there was a transfer out and he was again lost to follow-up. 2014, when he came back, he was diagnosed with XDR TB. And again, he was lost to follow-up. As you can see, he's 30 already, and you can see past 10 years back. So he was a teenager then. So this challenges also come with teenagers. And he started again 2018, but the last treatment which was started was June 2021. That time itself, he was given an information that this is the best treatment we can offer you right now, but we cannot assure you what will be the outcome. So he took this treatment, and he was very sincere now, and he did not miss any days of medication. He tolerated all the painful uh, uh, injections of amikacin, and also he had a mild to moderate hearing loss that on linezolid. He had a lot of side effects due to it, peripheral neuropathy, but he was trying to tolerate it. But lastly, initially there was a culture conversion happening, which is like the sputum culture was coming as negative, few samples, but again after a year, when imipenem was stopped after a year, when the culture conversion was negative, but then now at 2023, again, he started having positive sputum cultures. So this is a protocol in TB patients where like then cultures come more than 4 months of positivity. We need to stop the treatment. But also in his case, this was not a treatment to give we did not have any hopes during starting the treatment as well. As you can see, these treatment which was given, bedaquiline, linezolid, clofazimine, he was already resistant to it, and he was given high dose of everything. So now the point in August 2023, he was completely tired of taking the treatment at home. So, and he was worried about the infection, and he was also worried about he's not improving, he was deteriorating physically also. So, next, please. So, this time the examination, you can see the BMI is 15.9. Although the vitals were quite closer to normal, he had occasional like, of course, he had dyspnea, so occasionally he would get breathless, but there was no wheezing. And he has grade 3 peripheral neuropathy, which he is able to tolerate. There's no pain as such right now, which was bothering him. And you can see the mild hearing loss. Next, please. To just show you that the X-ray is from the recent, but this is the CT scan is from almost a year back, where you can see almost one side of the lung is involved. I mean, almost involved, and the other is partly. And also you can see the trachea shifted. So there is kind of the lungs have reached. They have a lot of damage right now. So if you can see the course of the next course for him without the treatment would be very difficult. Next, please. So here the psychological aspect is like he's a 30-year-old, unmarried, unemployed, and he was dependent on his parents. Plus, he's been struggling with TB for the past almost 10 years now. And kind of he had this guilt feeling that because he did not take the treatment well in the past, now he has this thing. And he was also tired of taking the drugs because he was not able to tolerate the side effects and had a lot of gastritis. He was not able to eat. He's not able to enjoy any social life. But at this point also, he wants to get better, and he at least want to try and visit his brother who stays in another city. And he had this hope that maybe there would be some new medications coming, and he will get a better treatment after taking a break from this treatment. And again, he had this fear that he will pass this infection to his family members. So he's trying to keep that distance also from the family. Next, please. So basically, as palliative care in TB, we don't have much of the options, and we don't have opioid access, we just have the basic symptomatic treatment as of now for him: paracetamol, ibuprofen, or bronchodilators, or if he needs additional support, he might get admitted to the hospital. That's it. Next, please. And the main concerns for him was how will he be addressing the pain and management for once the symptoms go worse, who will take care of him, and how he will be able to manage the infection control in the house also. So, I mean, for this patient, we can, next please. We can directly come to the discussion points that, firstly, I wanted to ask, how do we communicate to the patient that we are stopping the treatment, or we are giving them an option because even he is tired, he wants to stop, and what will be the consequences of stopping, and then we can go from there. Should I be answering, or like we discuss it?
No, I think let's our friends comment on this.
Okay. And this is coming from a real case situation.
Yeah. So this young man with multi-drug resistant tuberculosis, and actually want to stop all the medication because it is not going to be beneficial for the patient. So Riddhi is asking, how can we communicate it to the patient regarding stopping the treatment and reason behind it? Anybody has any idea? Please unmute and speak. Anybody?
If people are hesitating, I just wanted to say one thing, that this is a discussion. There are no right or wrong. Like we are just coming up with, from whatever we have learned, if we can think of something and brainstorm together.
Mukta, please take it up. Nobody is.
Yeah, based on, I mean, we have seen so many scenarios up till now, small ones. So based on that, can anybody, like, even if it doesn't have to be a complete plan, even if it's like a small suggestion from your side, how could you start to communicate, or what would you do first? We saw how to break bad news. So based on that, anyone?
Hello.
Yeah.
So, since the patient already knows that he has been on and off medical treatment for so many years, and that is probably the cause for his drug-resistant condition, would it still make sense to ask him, to give him the autonomy to say, like, what do you think is the reason why your body or you and your disease is not responding to medication, and then wait for him to answer and then kind of open the discussion?
No, you see, usually when we open the discussion, we would just find out what the patient knows. That's it.
Exactly. So, that
Like,
was what I meant. You ask how much he knows about the disease, because
yeah.
according to what Vidhi said, he is having some amount of guilt in him that he's responsible for the state that he's finding himself now. And I'm sure by now, over the 10-year period, the doctors have already explained to him that you've got this drug-resistant tuberculosis, which is not responding, and that some of the symptoms, the peripheral neuropathy and the other symptoms that he has, is because of the drugs. You still give him a chance to, take responsibility to kind of explain what he knows, what he expects, what his fears are, and then from that point, kind of take it one by one, chunk it, so to say, small pieces. So you can start with, say, okay, let's start with, this is what you know about your condition. Let's talk about that a little bit more. And then maybe after some time, talk about the fact that he knows he's got these peripheral neuropathy and other side effects. Talk about that. Would that be the proper way to go about it?
So see, first of all, ma'am, it's not just about giving them a chance to explain or tell about what they know. It's also for us to know whether the patient has really understood where the patient is when it comes to the grief cycle. Because again, that's not a linear thing. There are chances that the patient goes backwards and goes into denial after, let's say, he has moved on and understood. Like, it doesn't have to be that just because he was told so many times, he has really understood what has happened.
Yes. And
so it's always better to get to know first.
Yes. And I
where
think
the patient is at this stage.
And I think the process is not something that could probably happen over a period of 1 day or 2 days. You know, I think it would probably take like a week or even longer, because you would have to take it in little chunks, right?
Right. So these steps, they are not to be crammed into like one meeting. You decide based on each patient how you want to space it out.
Right. Okay.
Yeah.
Thank you.
There are some who would really move fast and you would be able to just have that entire conversation in a session, but most of them you will have to take your time.
And in this case also, along with the patient, again, you would have to have some amount of collusion with his family members also. After giving the patient the choice, would that make sense too?
Sorry, can you please repeat that?
It is like the first point is first to communicate to the patient to stop the treatment and reason behind it, and consecutive issues that have been dealt with. So again, here we will have to ask the patient, would you like someone from your family to be with you while we are discussing this, so that everyone's on the same page?
No. So now anyways, we will be talking to the family members. But this particular thing, what you asked, that depends on what has been if the patient has been an inpatient for some time, let us say, or, and you have anyways been in contact with the family and the patient, then it's not about specifically asking him who should know and who should not know and things like that. But when it comes to the decision making, definitely yes. Decision making in the sense that we are going to stop treatment, like curative treatment. So that is definitely something that would require, the patient will have to, considering that he's 30, definitely he would be wanting maybe his brother or whoever he is close to. Yeah.
Thank you, Mukta. Thank you, Riddhi, for getting this interesting case.
Anybody else has any inputs or any suggestions?
If somebody asks us how much time I have in my life, what is my survival, and how do you tell it in months or years, the ideal answer would be
That's a very difficult conversation to have. It's so would you like to say something on that?
Yeah. Am I audible?
Yes.
So this is a question which many of us will face, and first of all, in communication, the most basic thing is always explore. Okay, so if somebody asks how long I have, then I first of all I should find out why he is asking that question. So there would be a question behind that question. Okay, so find out that why they want to know. Okay, and they might have many things. We don't know what they are going to tell. Sometimes some people may tell, I would like my and I want to see that my daughter get married, or I want to write my will, something like that. Then you can actually, then you have to find out what they know the situation as of now. Okay, so you can ask, what do you think? After exploring the reason behind that, you ask, what do you think about the question that you have asked? So they may not be able to tell it in time period, but they may tell something to you. And then you have to actually give your input. So what we usually tell is that don't give any time frame as such. That is, you have 2 months to live, you have 6 months to live, or you have 1 year to live. You should not say like that. But you can actually tell the patient that um, uh, um, what is the time period with which your condition is getting worsened. That means, is your general condition worsening every day? Is your general condition worsening every week? Or is it by taking months? Then it is usually said that if you are deteriorated by every day, you have days to live. If your general condition is deteriorating by weeks, you have weeks to live. If your general condition is deteriorating by months, you have months to live. So we are not giving any time frame. Days may be from one day to any day. We but that will give them an idea. It is not very long, but at the same time, we are not giving 100 days or so many days. So that is what usually done. Otherwise, if you give the time frame, that will increase the anxiety of the patient. They will be looking at calendar every day. Oh, today is 99th day. Tomorrow I am going to die. Tomorrow is the 100th day. So this is how it is usually done. That's an important when the patients are asking, can we be ambiguous? So I would like to ask another question. Can we predict death with clarity? You have only 5 days to live. Do we have, can we predict? If we can predict, then we can do it with clarity. Otherwise, we need to be ambiguous, isn't it? You have to tell the patient also, I'm very sorry. There is, I know that it is very difficult because this is uncertain, but this is what I can say. Nobody can predict death unless the patient is actively dying. If the patient is actively dying, then probably patient will be unconscious. So he will not be asking the question.
I have a question here. Like in the communication, we read that give a situation of worst and the best scenario. But like, how will that help?
That's again the module, I think.
Yeah.
Worst and the best. So that's again stimulating the patient to think that, okay, if the worst thing happens, what all should I be prepared for? So that patient can actually prepare for that. But there is also a possibility that there can be a best situation in which he can go for long time. So that um, what do you call, they will have some, I would say, this if we are clear that he is going to clearly deteriorate, then I don't think you need to give best and worst case scenario. This is going to be the situation where you are uncertain about what would be the outcome. Otherwise, I think if the patient is clearly deteriorating and you think that he is not going to make it, then you should tell him, okay, this is what I believe. And some people may talk in terms of miracles, but I think miracles will happen once in maybe 1 in a million patient. So you need not talk about miracles. Yeah, time frame means I would not, that's what, days, months, or weeks. That's also a time frame, isn't it? But if you tell 6 months, that is going to actually increase the anxiety of the patient and as well as the family. So don't give the time frame as such, like quantify it in terms of 6 months or 1 month or 1 week. I know that there will be no clear answers for this, but this is what usually being done. And even there are some survival tools which are used in palliative care, but all those will make the patients more confused. So that says it would be like something like you have the probability of living for 1 year. The chance is 30% or 50%. So these all are prediction tools which are even available online. But I think rather than that, giving the actual time, days, weeks, or months would be better.
I posted a question and maybe like how to counsel when the patient feels guilty about its own, like in my case also, he feels now he overcame that guilt, but guilty of not taking the treatment on time, and now the situation is worse. So how do you counsel for that?
First of all, always acknowledge, always make space for that guilt, because it's valid, right? I mean, don't invalidate that emotion. Don't say things like, what's the use of feeling that now, and stuff like that. So let them express that guilt, and only when they have completely expressed that guilt, then you can maybe shift a little bit to being solution focused, in the sense that you can just change the direction of the conversation a little bit and say that, okay, yeah, now that all that has happened, what do you want to do about, like, what do you want to do now, and how do you want to like what to say, like looking into the future, what do you want to do now with whatever time is left. So he might not be able to undo that. That should be very clear. Don't give them false hope that they can undo all of that. But so basically divided it to two, give them enough space to express the guilt, and only then, just to make sure that they're not wallowing in that guilt and staying in the past, you bring them to the present and say that, okay, These are things which are possible right now. So let's talk about that. But don't rush to that second stage.
Riddhi, I would like to ask you another question. If somebody with tuberculosis, if they are treated properly, can there be a chance that they can come up later with multi-resistant drug tuberculosis?
So, I mean, we have been cases where like the patient was treated for DSTP and they were all fine, but now they were exposed to some MDR strain. So there can be TB again without being the same bacteria from their own body, because they are living in the same area and again they are exposed to TB. But if the DSTP treatment was taken properly, there are less chances of it being still thriving, but only if it was not treated well or still they had a cavitary lesion. So then that can have the cavitary lesions are very difficult to get rid of it just with the treatment. So there are surgeries and all the other options as well. But if in case it was not treated well, be it maybe drugs are not good, or sometimes the patient might have not taken it correctly, or so sometimes like it happens, but we cannot really exactly pinpoint what and how they were like when they have it a second time. We assume these are the possibilities, but we cannot exactly say what was the actual cause, except when we know there was a poor adherence of the patient. In that case, definitely it was because the patient did not take the medication correctly, or the doctors did not give it correctly.
Okay, Riddhi, why I asked that question was, I'm not an expert in TB, or even I know only about the regime. So, in case of lung cancer, we know that lung cancer has a strong association with smoking, but there are some lung cancers which can even come without smoking, isn't it?
Yes,
So,
yes.
if as Mukta told, first of all, I think we have to give space for them to express all their guilt and things like that. And if it was this is one situation where even I will lie to the patient, because we need not make them feel guilty again and again. So I would even tell, okay, there are many other patients who have cancer and they do not smoke. So is smoking the only reason for the cancer? No. Lung cancer? No. So
No.
if even if you have not smoked, then also you have a chance of getting lung cancer. So I don't know whether I'm correct or not, but this is where I would took my common sense and will tell them. So that's why I asked whether even if the patients are treated with anti-tuberculous medications, is there a chance, 100% chance, that they will not get multi-resistant drug tuberculosis later?
No, that is not there. So
yeah. So
they can get it
this is
anytime.
something.
Anybody can get it again.
Yeah. So I don't know whether this would give you something to talk to him, but I think if somebody is feeling fully guilty, and then even I may take this approach. From the psychological point of view, Mukta, I don't know whether it is right or wrong.
No, so I mean that is a very, I think, subjective decision to take, depending, like you said, depending on the intensity of the emotion that that person is facing. If we find out that the person is stuck in that guilt and there's nothing else that they're looking at, and they're not really looking at things like their unfinished business, and like whatever they can do to live life right now, whatever is left, then definitely I think like what sir said, we can uh, like bring in this possibility, because then we are not basically lying to the person, we are just bringing in a possibility and making them think of it, just to get them unstuck from that intense emotion.
I just want to tell you that in our case, which we use, we have an area to write about personal habits. So we have decided that we will ask about personal habits only if it is going to make some difference for the patient. If a patient with advanced lung cancer, he has smoked, and that information is, if we ask them, that will make him feel again and again guilty. So that's what we are doing in our institution. But if that is going to make the difference, then definitely we have to ask them.
Yes. Thank you.
Mukta, do you have anything else to tell us regarding this patient?
So nothing in particular. I think we have like discussed quite different facets of it, and people have also come up with suggestions. So, Dr. Riddhi, if you have something to add, or like some additional question about the patient or something, or if you want to tell us what you did or have been doing to manage.
Like I don't have anything else, but I mean, in this case, he was really, I mean, when I met, because this was the recent time when I met him, and already he had been on and off treatment and the trial, so he was aware about everything what was happening with him. So his only concerns were when he goes off the hospital, he just was admitted for 15 days. So we told that, I mean, he was hopeful about new medication and everything, but then we made sure, like we did discuss that, why do you think so? But right now there's nothing in research. Maybe if something comes up, we will definitely tell you. But at this moment, there is nothing that we can give you any new treatment. Even after a 1 year, 6 months, there was definitely nothing coming up. But when he left, and this was a discussion where he wanted to be alone. He didn't want his father to be involved. So we respected that, because it's been a while that every whole family was involved, and he is like, I don't want my dad to be listening and I want to discuss everything clearly face to face. Plus, when he left, he wanted that, oh, I'm working right now in Uzbekistan. So like it is similar, like we have a vertical program, they also have it. So, and a lot of stigma is also there attached. So once the TB treatment is over, that they are not concerned about the patient, because the TB drugs are not being given to the patient. So then the patient was like, what will happen to me? Who will take care of me? Where should I be going? If I need medications, who will take care of Anish? He didn't wanted to go to the primary care. He wanted to come to the TB care. So we made those kind of arrangements, and then we met him after on the OPD. Then he was slightly like convinced about it. Then he made plans to go to the city to meet his brother. We said, okay, you can think about it when you feel well. And when we met him second time, again, he came to his own wishes that I'm not feeling well, so I will postpone it until the next time. So we never spoke about the timelines or anything. We just said, what are you planning and how you can navigate through that with the existing health. Thank you.
Okay. So I think we had a very good discussion on various aspects of communication. And thank you, Riddhi, for bringing this patient story, which was indeed a challenging patient story. So I think we can wind up this session for today. And thank you, Mukta, for being